Hello, I'm Kerry Robertson, Associate Professor, Division of Urology, Duke Urology of Raleigh and Duke Urology of Durham at Duke Cancer Institute at Duke University Medical Center in Durham, North Carolina. Today we will talk about the principles of focused ultrasound therapy of prostate tissue. I would like first to acknowledge the contributions of Dr. Christian Chelsea and Dr. Stefan Turoff of the Clinic Harlequin in Munich, Germany, for contributions to this presentation. In addition, I would like to disclose that I'm a consultant to the EDAP TMS corporate concern in Lyon, France, and have served as the principal investigator for the EDAP clinical trial of high-intensity focused ultrasound therapy for low-risk, low-stage prostate cancer between years 2006 and 2015. This is a cartoon that describes focused ultrasound for prostate tissue treatment. At the top of the slide, you see the term HIFU. This is a short abbreviation for high-intensity focused ultrasound. This technology, which has been in development for over 2 decades, is positioned between curative and palliative therapies for prostate cancer. You can see from this cartoon that curative therapies or definitive therapies are frequently listed in the surgical as well as the radiation sphere, whereas palliative therapies are frequently listed, such as hormonal therapy, in the palliative sphere. It is possible with emerging technologies for direct in situ ablation of prostate tissue that mixed results, such as curative and palliative therapies, may be achieved with these technologies. First, I would like to say that the HIFU literature is relatively limited. We should know that negative biopsy is most often used as a surrogate for success in cancer control, and that 10-year biochemical outcomes are just now becoming available. So, what is HIFU? As you see here in this picture, you have a control module with a stool on the right, and you have a patient treatment table with a probe depicted in a magnified view. What we can say about HIFU is this is a pulsed-focused, extracorporeal, non-invasive robotic surgery, which works similar to extracorporeal shockwave lithotripsy. This probe may be positioned transrectally and be placed adjacent to the prostate for through transmission of ultrasound energy through the rectal wall and into the prostate tissue. The probe itself allows for direct focusing, harmless passage of ultrasound energy, and for this focused energy to be directed to a pinpoint, creating a streak of ablation, which will create confluent areas of thermal change and injury to the prostate tissue. Each lesion is about the size of 2 or 3 grains of rice, stacked end to end. And with systematic pulsing through the prostate, complete ablation of the targeted tissue may be achieved. Obviously, this can be a small zone of tissue ablation or can include the entire gland. Here we see that during treatment planning, the target volume is defined by ultrasonography, and the red marks are the actual treatment sites, the streaks through the prostate in a vertical direction. The energy begins at the focal point and moves toward the probe. A prolonged exposure to energy will result in a thermal burn through the prostatic capsule and possibly into the rectal wall. For this reason, the length of time of the thermal energy is tightly controlled, and the distance between the rectal wall and the probe is tightly measured and monitored. This allows for safety mechanisms to be in place at all times and for immediate shutdown of any aberrant measurements or positioning to the probe within the rectum. After HIFU, one can see a conversion from glandular tissue to stromal and fibrotic tissue, as we see here in a 6-month HIFU prostate biopsy. This fibrosis results in residual tissue and volume reduction of the prostate, and in previous clinical experiences, prostate volumes of around 25 to 30 cc's post-HIFU have shrunk to 5 cc's. This also results in some bladder neck shrinkage. The indications for HIFU have to be considered in the context of its history. So at the beginning of the development of this technology, in 1996, this was felt to be a possible therapy for localized prostate cancer for those who did not qualify for radical surgery. Contraindications were obvious. Patients without rectal access, tumor infiltration to rectal wall, patients with radiation-induced rectal wall damage, or possibly rectal stenosis after previous rectal surgery were certainly not good candidates for this technology. However, by 2007, HIFU, after published reports and clinical experience, had moved to a point of acceptance within the sphere of definitive, curative, or adjuvant palliative therapy. Here we see the various definitive therapies and the role for HIFU in combination with possible tissue reduction of the prostate with preparatory transurethral resection. In clinical centers that have developed this technology, particularly in Europe, it is not uncommon for transurethral resection of the prostate to reduce the prostate volume as well as the anterior-posterior diameter or height of the gland, rendering the prostate suitable for complete treatment. We know that by precision with interactive transrectal ultrasound scanning, that virtual planning can be very accurate, and the actual application of the energy mimics the planning. During the treatment, an intrarectal balloon surrounding the probe will compress the prostate, and previous transurethral section of the prostate may reduce the height of the gland, allowing the vertical streaks or thermal areas to completely encompass the anterior as well as the posterior boundaries of the prostate. As we can see here, in the European experience, in Germany as well as France, that prostates less than 40 cc's in volume may actually be suitable for immediate prostate resection and HIFU in the same setting, whereas larger glands may undergo better stage treatments with resection of the prostate followed by a period of healing followed by HIFU. There are several devices available for high-intensity focused ultrasound of the prostate. And here we see a lithotomy position with one device and a lateral decubitus position with the alternative device. One should realize that bubbles can accumulate within the rectal space during the HIFU therapy, and these may rise and obscure and affect the interface. A lateral decubitus position may have this as a problem less often. Here we see a treatment with the Ablatherm device with a lateral decubitus position and the operator at the control panels. The control is computer assisted. The initial phase of positioning is critical with direct alignment to the prostate and the correct distance to the rectal wall. Finally, monitoring and application will occur in real time. Catheter placement is made at the time of the therapy, but the catheter is removed during the treatment of the interior of the prostate to allow for full transmission of ultrasound energy and no blocking of the catheter, of the energy by the catheter. Early published experiences with HIFU for total gland ablation and low-risk prostate cancer was associated with very small positive biopsy rate 1 year after HIFU therapy, and an acceptable 5-year disease-free rate of nearly 78%. Subsequently, multiple publications have described negative biopsy rates, both with the Sonoblate device as well as the Ablatherm device, as well in Europe as well as in Japan. We can see the dates of these publications and the biopsy rates depicted. One can say that the negative biopsy rate is associated with a single treatment in approximately 70 to 80% of cases. And in some cases, patients will undergo a second HIFU and be rendered disease-free after the second treatment. Comparing these results with established definitive therapies such as radiation therapy or radical prostatectomy, one can see in the literature a wide variation in clinical results in reference to biochemical progression or disease-free states. It can also be stated that for low-risk and intermediate-risk disease, there are some similarities to definitive therapy, particularly radical prostatectomy. More recently, in encouraging HIFU literature reviews, Creuset from Lyon, with a published volume of over 800 patients, reported a 5-year biochemical disease-free rate of 83% for low-risk disease, 72% for moderate-risk disease, and 68% for high-risk disease. And at 7 years, there was a 75% biochemical disease-free rate for low-risk disease. The negative biopsy rate was similarly successful, with only an 85% negative biopsy rate for low-risk disease, 74% moderate-risk disease, and 72% for high-risk disease. The metastasis-free survival at 8 years was 97%, and cancer-specific survival at 8 years was 99%. Prentice also has published data of over 440 patients with biochemical survivals at 4 years of 76% in low-risk disease and 62% of moderate-risk disease, and a positive biopsy rate of 7.6% in a non-stratified population. These patients underwent no pretreatment with hormones, no TURP, and received a single session HIFU. Lana has also reported nearly 400 patients looking at low-risk, moderate, and high-risk disease, recognizing that these patients met qualifications for effective whole gland HIFU with equal to or less than 24 millimeters anterior-posterior height, and that 5 and 7 year data showed a favorable biochemical disease-free rate of 88% and 80% for low-risk disease, 78% and 64% for high-risk disease, with negative biopsy rates of 86 to 74%. Comparing definitive therapies to emerging technologies may be very difficult. One guide to this would be the effort to look at a meta-analysis of published literature. And here we see an example of the 2007 AUA treatment guidelines update with a meta-analysis and comparison to published high-quality results. In a similar methodology, HIFU has been compared utilizing the reported outcomes of at least 50 men per published publication, including T1 and T2 disease, and also reporting efficacy and morbidity data. Overall, 22 papers were reviewed. Here we see the AUA guidelines data with survival curves for low-risk disease, comparing brachytherapy, prostatectomy, and external beam radiation therapy. One can see that there can be significant variation in long-term outcomes. However, looking at the groups as a whole, it is safe to say that very respectable 80 to 90% long-term control rates have been experienced with all 3 modalities. Similar results have been reported for HIFU. Looking at moderate risk disease, we see smaller control with brachy, prostatectomy, and external beam radiation therapy, and a very similar level of control is published for HIFU. Comparing the range of biochemical survival rates, brachytherapy in the literature in this review was considered to be effective with external beam radiation therapy as a comparator in 75 to 98% compared to 68 to 95% for low-risk disease, and 69 to 85% compared to 52 to 100% for moderate-risk disease. HIFU showed a similar efficacy of 74 to 88% in low-risk, 46 to 83% in high-risk disease. And for the traditional surgical results, one sees a wide variation at low-risk disease of 66 to 100% and moderate-risk disease of 38 to 95%. So the conclusion from this would be that HIFU may have a place as a definitive treatment. Also, morbidity becomes a big comparator. We can see from looking at the meta-analysis on morbidity that there may be actually favorable outcomes for erectile dysfunction, gastrointestinal side effects, comparable outcomes for GU side effects, as well as fistula, and that prostatectomy, bladder outlet obstruction, and stricture rates may be similar and certainly higher than that for radiation therapy. And here we see the morbidity comparison charts. Although a very difficult and busy slide, the red bars outline the erectile dysfunction side effects for brachytherapy, prostatectomy, external beam radiation therapy, and HIFU. One can see significant similarities. Also, in terms of urinary leak and fistula formation, for brachytherapy and external beam radiation therapy, we see a minimal to zero fistula rate in the published high-quality literature. There is a small published rate for prostatectomy fistula and a minimal published rate for HIFU. In general, one can expect a 0.5% fistula rate for brachytherapy or external beam as monotherapies and 0.5% fistula rate for prostatectomy. More recent series with evolving technology for HIFU have reported zero fistula rates. In terms of GI and GU side effects, mostly GI, we see a greater preponderance of GI side effects for radiation therapy. In reference to bladder outlet obstruction and stricture, one sees a comparable stricture rate and bladder outlet obstruction rate for HIFU and prostatectomy, and less of an issue with radiation therapies. So, if one believes that targeting within the prostate tissue an effective ablation may be an effective and desirable treatment, can one do a subtotal gland ablation, or can one do a focal therapy? It is certainly reasonable and theoretically possible to target within the prostate and only treat an index lesion, or only treat one half of the gland. This so-called focal therapy may have the advantage of potency preservation, possibly fertility protection, and certainly treating small volumes with less morbidity. It is unclear whether this would result in comparable cancer control rates, however. Such focal therapy has been tried and successfully employed in salvage therapies for post-radical prostatectomy or post-HIFU residual disease or post-radiation therapy residual disease. And here we see examples of these conditions. In terms of salvage treatments for recurrent prostate cancer after radiation therapy, published data have been compared in this slide to brachytherapy, cryotherapy, and surgery. Amling data looking at 108 patients post-radiation therapy who underwent radical prostatectomy experienced a 51% incontinence rate and a 43% disease-free survival rate. Comparing to HIFU, one sees a similar disease-free survival rate, but a lower incontinence rate. Certainly, urethral obstruction at 16% was similar to urethral obstruction at 21%. Brachytherapy and cryotherapy post-radiation therapy also have significant concerning morbidities. So, HIFU as a hemiablation to reduce morbidity has been investigated for patients who have failed radiation therapy. And here we see the eligibility and inclusion criteria for a multi-center trial within the European forefront. We see that patients who have a PSA less than 10 and who failed after radiation therapy are staged with multi-parametric MRI and MRI-guided biopsies if necessary. And the patients receive a 12-core biopsy. We see this as an example of potentially reducing morbidity but preserving efficacy. Another alternative for focal therapy would be nerve-sparing or partial treatment of primary disease, which would allow for potency preservation to a greater degree than whole gland therapy. However, this could include the risk of later prostate cancer formation in untreated tissue. Here we see a zonal strategy as published by Dr. van Delthoven in Brussels with 32 patients with a mean PSA score pre-HIFU of 5.2 and a mean Gleason score of 6 with a PSA nadir of incomplete treatment of the prostate of 0.93. This should be compared to the PSA nadir for whole gland HIFU, usually less than 0.5 nanograms per ml. On follow-up, PSAs remained stable in 90% of patients, and a few patients went through biopsies with 3 out of 4 having negative biopsies. And there was over 93% preservation of continence. Following on the early experiences with this focal therapy, the French Urology Association has launched a 14 investigational center hemiablation trial for focal therapy of primary prostate cancer. These patients may receive prostate biopsies with MRI guided if needed. PSA's eligibility would be less than 10 and Gleason scores equal to or less than 7. Normal continence and potency. Patients received 12-core biopsies in MRI-oriented biopsies at 1 year. To date, these patients have experienced good results, although these are not published. This is an example of an MRI image post-HIFU. On the right, we see a zone of ablation. The patient in this particular example experienced no incontinence and did not report any significant erectile dysfunction. So in terms of proof of principle, focal ablation seems viable with HIFU technology. A number of efforts are in place to explore this more effectively. I should note that Duke has sponsors a focal therapy symposium annually in combination with Erasmus University in Amsterdam, as well as University of Southern California. These focal therapy symposia have been in force since 2008. In addition, other institutions offer prostate ablation courses. One should know that published series of HIFU focally are beginning to become more common, and actual focal cryotherapy as a comparator should be recognized. And recently, the COLD registry publication described that over 20% of cryotherapy patients for localized prostate cancer were treated focally. So this is an issue that needs careful thought and resolution and will take several years of clinical investigation to sort out. More importantly, though, now, is to understand HIFU morbidity. If one is to compare HIFU in terms of definitive therapy and efficacy, one must also compare morbidity. I would now like to show you the data from the INLIGHT trial, which is a low-risk localized prostate cancer trial utilizing whole gland HIFU. This study was an original investigational device study, experienced significant success in recruiting high-quality patients, and established initially an ASTRO criteria for failure, converting to a Phoenix criteria for failure as an endpoint. Should be reminded that the Phoenix criteria for failure as an endpoint is PSA nadir plus 2.0 nanograms per ml, and this is the standard criteria for failure after external beam therapy, radiation therapy, or brachytherapy. Here we see the eligibility data for the U.S. FDA IDE trial. 135 HIFU subjects were enrolled at 13 sites in the USA and in 1 site in Canada. DeMeco low-risk patients only, and no previous prostate cancer treatment was allowed. HIFU was performed without size reduction or transurethral resection of the prostate gland. These are the study sites that contributed to the trial. The demographics reveal a prostate volume on a mean average of 22.7, a Gleason score 97% of patients at 6, a clinical stage of T1C in 81% of patients, and 82% Caucasian and 13% African American. We also note that the NATR and ASTRO survival data with an intent to treat and 24-month completion data suggests that the PSA nadir less than 0.5 nanograms per ml was achieved in 74% of all subjects. The ASTRO success rate was 64%. With one combining the negative biopsy rate of 72%, we see a combined nadir and ASTRO in biopsy data of 45%. However, a complex and a composite endpoint is not standard therapy approach or clinical research strategies. It must be recognized that that is an unusual event. More importantly, it would be appropriate to look at a standard PSA criteria for failure. Here we see the Phoenix biochemical survival at 2 years, and at 24 months, 90.5% of subjects had a negative failure rate, and with an intention to treat analysis, including attrition, 77.8%. More importantly was a negative biopsy rate of 72%. This is a monotherapy without size reduction. Looking at the data from the European literature, this is similar to European published data of approximately 30% biochemical failures or positive biopsies prompting a second HIFU treatment. The INLIGHT trial was designed only for a single treatment. Here we see the 2-year and 5-year survival data of the pooled data of 92 to 83% at 2 and 5 years. We also look at data that was accumulated through the clinical treatment sites in Europe, utilizing the eligibility criteria for the North American study. Using this long-term refined data, over 220 subjects were reviewed with a mean age of 68 and the prostate volume of 27. We see a Gleason score preponderance of 6 and a T1C preponderance for clinical stage. And indeed, as one would expect, there was an excellent long-term disease-free rate from metastasis at 10 years of over 95%. So the long-term refined cohort 8-year freedom from metastasis was 98.2%. And we also look at the prostate cancer-specific survival and see a 99.1% cancer-specific survival. So this is what one might expect for active surveillance. And indeed, to compare active surveillance to HIFU, comparator on a meta-analysis basis was completed looking at the PIVOT data, which was the active surveillance clinical trial in prostate cancer. And one can see that at metastasis at 8 years was very similar in the PIVOT data in the active surveillance arm, and also comparing to the radical prostatectomy arm. So primary effectiveness comparison with freedom metastasis following HIFU is similar to the PIVOT arm of radical prostatectomy. Mortality at 8 years, looking at the HIFU long-term cohort, showed no evidence of inferiority and supported effectiveness comparison between cancer-specific survival in HIFU-treated subjects and the PIVOT arm utilizing radical prostatectomy. In addition, one could look at metastasis at 10 years and see that in the SPCG4 study looking at active surveillance for prostate cancer, that HIFU metastasis rates were very similar to those for the radical prostatectomy arm. And one can also see that prostate cancer-specific survival following HIFU was similar to the SPCG4 radical prostatectomy arm. Looking at this in total, one can see that the most dramatic set of data from this comparison was the similarities in long-term biochemical survivals and deaths from prostate cancer. Going back to morbidity, however, in the IDE trial, it was important to recognize that with a follow-up of nearly 15 months, there was a 0% fistula rate. However, these patients received thermal therapy to their prostate and requiring urinary drainage for up to 1 month or longer in some cases. And these patients were carefully monitored for all adverse events. The urinary tract infection rate was approximately 27%. Catheter removal time frame averaged around 17 to 18 days. There was an incidence of additional inability to void at 33% and a subsequent stricture rate of about 2% in the immediate treatment period. The late onset of urinary retention occurred in 8% of patients, and there was a long-term stricture rate or contracture rate requiring some form of intervention in 31% of subjects. So here we go with the pad-free incontinence rates, which progressively improved with time up to 24 months, so that by the end of 24 months, greater than 90% of individuals were pad-free. However, one can witness that there was a period of decreased urinary control within the first 6 months of post-HIFU. Looking at potency, a similar decline in potency was experienced with a recovery phase. Understanding that these patients underwent total gland HIFU with the margin of the ablation to or slightly beyond the capsule, so that at 1 year, 24% of subjects reported a sufficient recovery of their erectile function, and at 2 years, 27%, with partial recovery in 35 and 24%. In terms of voiding discomfort, one can see an increase in the IPSS scores from a baseline of around 6 to a baseline up 1 month score of around 17, improving near baseline at 24 months. So one can say from this morbidity data from this carefully monitored, carefully recruited, highly selected population of subjects receiving monotherapy with HIFU without transurethral section of the prostate or bladder neck, that fistula rates were 0, and the fistula can be considered essentially historic, utilizing newer technology for HIFU. Continence and potency recovery with time are encouraging. The fact that the patient did not receive a transurethral section of the prostate gland likely increased the urinary morbidity, including the urinary tract infection rate, and that one can also state that this morbidity compares well to other therapy morbidities. This is a cataloging of all the adverse events recorded during the clinical trial. And as we understand, clinical trials are a much more rigorous circumstance, and the recording of any deviation from baseline may be listed as an adverse event. The main point from this is that over time, the resolution of these adverse events was nearly uniform. It should also be recognized that literature does not contain this level of detail for any therapy as a rule. So we look at incontinence and fistula and see that incontinence improves and erectile dysfunction improves. Fistula does not occur and did not occur in this population. So some ED will persist in these patients, and it should be important to tell subjects who are considering HIFU therapy that ED is a definite risk. Most importantly, however, is that patients should be informed that they are likely to receive thermal injury to the urethra with a predictable 15 to 20% incidence of urethral narrowing. This will likely be a soft stricture, which will require some degree of dilation or incision, but frequently stabilizes at 12 months, and no further interventions are required. From this IDE data, one can see that the urinary obstruction was likely related to the ablation of the prostatic urethra, but most often resolves. And here we see a timeline of 24 months where this degree of urinary obstruction resolved to a low level over time, over 24 months. And again, the graphic depiction of the drop in the UCLA urinary symptom score with a resolution and return to baseline by 24 months. Here we see a cataloging of the other morbidities with this clinical trial, ranging from small amounts of hematuria, some minor amounts of pain, to some incomplete voiding. And it should be recognized that other adverse events, which are common with any prostate cancer therapy, will tend to resolve with time. Here's a cataloging of the major adverse events, including erectile dysfunction, urinary incontinence, urinary retention, obstruction, stricture, and fistula formation. Again, one may not see all of these adverse events carefully described in a longitudinal series of radical prostatectomy or external ring radiation therapy. And I would remind the viewer that this IDE trial was carefully monitored for all adverse events. So where are we? HIFU is a non-invasive, no-incision or excision therapy for prostate tissue. Does it have an applicability in localized prostate cancer? Data suggests that it very well may. The question is, how does one measure endpoint, how does one measure efficacy, and how does one compare morbidities? In the HIFU IDE trial, likely the most important parameter was the negative biopsy rate of 72% for a monotherapy. Again, this should be compared in terms of a primary treatment in comparison to radical prostatectomy, where patients will sometimes require radiation therapy after biochemical failure, or at the time of therapy and surgery when they have positive margins or extracapsular extension. In addition, one must compare that monotherapies are unusual in cryotherapy and radiation therapy, and that hormone therapy is commonly employed. So the question becomes, does HIFU have a place for focal therapy of prostate cancer? And here we see a listing of the competitor technologies or the complementary technologies which are in development. And time will tell whether these other technologies are better or more suited for localized treatment for the prostate cancer. One can say, though, that the proof of principle for HIFU has been met, that tissue may be safely ablated in a focally delivered fashion or to the entire prostate if the prostate is of small enough size. And the proper place for HIFU is yet to be completely determined, and I again submit that we should maintain a careful review of this HIFU as both potentially curative and also palliative technology. Thank you very much for your time.